So this would be a rapid review session of acute leukemias. At the very beginning, I would like to tell you that acute leukemia is approached in 20th century by the FAB classification system, which stands for not for fabulous but for French, American and British FAB classification system. But currently in 21st century, we follow the WHO classification system. So previously in the older FAB classification system, which was introduced in 1970s, the criteria for calling a disease or disorder acute leukemia is more than 30% of blast in the bone marrow typically. But currently in WHO classification, what we follow is that the cutoff limit is decreased to 20%. And this, be careful, that is more than or equal to 20% blast in peripheral blood or bone marrow. So if you get more than or equal to, even including 20% blast, it could be myeloblast in case of AML, it could be lymphoblast in case of ALL. In the peripheral blood or bone marrow, even in peripheral blood also, not only in bone marrow, the case would be diagnosed as acute leukemia. And there is another change which has been brought in the WHO classification system. Even in some cases of current WHO classification system, even if you don't have 20% blast in the bone marrow or the peripheral blood, still those cases can be categorized as acute myeloid leukemia, particularly if they have some characteristic translocations like translocation 1517, translocation 821, inversion 16. This was not there in the older FAB classification system. FAB classification system, the 30% was absolute criteria. But in current WHO classification system, another key change is that the cutoff limit 20% is not absolute. Even in some condition, even if you have less than 20% blast in the peripheral blood or bone marrow, still that case could be regarded as acute leukemia, acute myeloid leukemia particularly, if they have those characteristic translocation which are associated with AML, which I mentioned, translocation 15, 17, inversion 16, or translocation 821. So in a nutshell, there are two concepts that you need to know. Currently, we follow the WHO classification system for the characterization or the classification of the acute leukemias, and in that criteria, to call a condition as acute leukemia, you need to have more than or equal to 20% blast in peripheral blood or bone marrow. Now, the next question that should come in your mind, that why in acute leukemias the percentage of blast is so high in the bone marrow. The reason for this in acute leukemia is occurring, there are two factors that you need to understand. Acute leukemia, one side there is uncontrolled proliferation of the blast. Like for in the myeloid series, you know that there are myeloblasts, then there is promyelocyte, then is myelocyte, metamyelocyte, band from neutrophic. Now all those early stage, those myeloblasts, they are proliferating in an uncontrollable fashion in case of acute leukemia, like for example in acute myeloid leukemia. And the second thing is occurring, those blasts, they are stuck in the blast stage, they cannot be converted into the next stage, the next mature stage. That means they cannot match into the myelocyte, metamyelocyte band from this. So that's why what is happening, at one side there is uncontrolled proliferation of blast occurring, and those blasts are remaining at blast stage rather than being converted into more mature forms. So that's why the percentage of the blast in acute leukemias are so high. And first, obviously what happens that their number increases in the bone marrow, and when their number becomes too much in the bone marrow, they spill over into the peripheral blood. So that's why the definition of acute leukemia contains that there should be more than or equal to 20% blast in the bone marrow or peripheral blood. In any of them, there is more than or equal to 20% blast, would be regarded as acute leukemia. Now, if you understand this concept, it's very simple to understand the general presentation of acute leukemia. Acute leukemia usually presents with a rapidly developing, with abrupt stormy onset of bone marrow failure. So the patient would be developing easy fatigability because there is anemia. There would be presence of recurrent infection and bleeding manifestation. Why they are happening? Because all those blasts which I mentioned already, that they're rapidly proliferating, they are actually crowding out the normal population in the bone marrow. Bone marrow is a limited place. And obviously, if the normal population gets displaced by this abnormal neoplastic tumor, blastic proliferation, so they would damage they would destroy the normal RBC precursors there, resulting in the development of anemia. If they destroy the normal WBC population, so there will be no healthy WBCs in the peripheral blood, resulting in recurrent infection. And if they damage the megakaryocytes there, obviously the resultant effect would be that there will be no platelet, resulting in episodes of mucocutaneous bleeding due to thrombocytopenia. So both AML and ALL, their key presentation is common, that is presenting with a rapidly developing bone marrow failure. And obviously there will be some other features which you can see in other acute leukemias, like acute myeloid leukemia, particularly the M4 and M5, the monocytic variant. You can get leukemia cutis, the skin involvement by the leukemic cells. You can get gingival involvement. Why? Because monocytes, these M4 and M5 are actually monocytic variant of the acute myeloid leukemia, and monocytes have a tendency to infiltrate into the tissues. That's why they usually go there. CNS involvement is more common in ALL, but CNS involvement is also seen in this M5 variant. M3, M4 and M5 variant. M3 is also known as acute promyelocytic leukemia currently. They are also associated with DIC. And DIC, disseminated intravascular coagulation, is particularly common in the APML, which is previously known as acute promyelocytic leukemia, or translocation 15-17 associated acute myeloid leukemia, which is previously known as M3 variant. So acute myeloid leukemia can also present with DIC. ALL on the other side can present with testicular mass, mediastinal mass, particularly in the T cell ALL. Acute leukemias can sometimes, particularly the ALL, can present with sternal tenderness, because the marrow is expanding actually, then they can infiltrate the subperiosteum. ALL particularly can also present with lymphadenopathy. Hepatosplenomegaly could also be seen in both acute leukemias, particularly in the ALL. So acute leukemias, the presentation, if you note, they can present with the presentation of generalized bone marrow failure, which is of abrupt stormy onset, rapidly developing, that is anemia, thrombocytopenia, neutropenia. They can present with some kind of organomegaly. In case of ALL, you can get testicular mass. M5 AML and ALL particularly, you can get CNS infiltration, central nervous system infiltration. So these could be, and DIC, particularly in the acute promyelocytic leukemia. So this, and gingival infiltration and the leukemia cutis, that can be seen in particularly the monocytic variant of the acute myeloid leukemia. So these all, there could be presentation of the acute leukemias, and you need to keep in mind. Particularly they love to ask about the APML. So they would give you a history of a patient with maybe 25% myeloblast in the peripheral blood, and then there is decreased thrombocyte count, increased prothrombin time, increased APTT, increased fibrin degradation products, and then they ask you what is the diagnosis. So basically they're giving you a case of acute myeloid leukemia, because they're telling more than 20% blast, more than or equal to 20% blast, and they're also giving a lab findings of DIC, disseminated intravascular coagulation. So they want you to point towards that. They are indirectly asking, this is a two-layered question actually, they are indirectly asking you that which is the most common AML which would be associated with DIC. Answer would be acute promyelocytic leukemia, which is also known as AML associated with translocation 15-17. This is a key point you need to know. And acute promyelocytic leukemia, there's another thing they will be asking you, that is the hour rod. Hour rod can be seen in the neoplastic myeloid cells, but particularly they are more common in the M3 or APML, acute promyelocytic variant. And when there are too many these hour rods are seen, actually these cells are called faggot cells. And acute promyelocytic leukemia, which is particularly loved by the examiners from the AML, they have another important feature that is associated with, they can be treated by vitamin A derivative, particularly ATRA, all-trans retinoic acid. What actually all-trans retinoic acid does, that if you look at the pathogenesis of acute promyelocytic leukemia, that is associated with translocation 15-17, and there is a formation of abnormal fusion gene PML RAR alpha, RAR alpha, that is promyelocytic leukemia, retinoic acid receptor alpha, as a result of the translocation 1570. And that disrupts actually the vitamin A metabolism. And what happens, the promyelocyte, myeloblast promyelocyte, those neoplastic promyelocyte, they remain as promyelocyte. They cannot mature into myelocyte, metamyelocyte band for neutrophil. When you are treated, they are treated by this all trans retinoic acid, this blockage is overcome. So now the promyelocyte could be converted into myelocyte, metamyelocyte band form neutrophil. And you know that mature neutrophils, they usually die within 6-7 hours. So all those, they actually helping them to die out very soon. And what is the risk about the acute promyelocytic leukemia? There is always the risk of DIC, particularly the granules are there, and there could be some pathology in the fibrinolytic system also, fibrinolysis. So there is an increased tendency of the bleeding disorders which can be seen in acute promyelocytic leukemia, and that's why it could be quite life-threatening. So that is a key concept that you need to keep in mind about the acute promyelocytic leukemia. And then they usually ask about the risk factors for acute leukemias. The risk factors for acute leukemia could be Bloom syndrome, ataxia, telangiectasia, radiation exposure. Particularly, I like to mention about Down syndrome. Down syndrome, you need to know that Down syndrome can cause both AML and ALL. But if the child is less than 4 years of age, there is more risk of developing AML. And they can also develop ALL, but ratio is usually AML to ALL 1.2:1. That means if 1.2 child develop AML, is roughly 1 would be developing ALL. And there is 150 times higher risk of developing AML in a less than 5 years age of child. So particularly less than 4 years of age, a Down syndrome child, there is higher risk of developing AML. And after that, the most common leukemia which is developed in Down syndrome patient is obviously ALL. That is the point you need to keep in mind. And another thing they will be asking you that which variant of AML is more commonly seen in Down syndrome patients. Answer would be M7, the old M7, or acute megakaryoblasttic leukemia. Usually we see a lot of megakaryoblasttic variant actually. And megakaryoblasttic leukemia usually associated with very poor prognosis. They have bone marrow fibrosis. This is another point about you need to know about this thing. As another thing they would ask you that the stain, cytochemical stain, usually for the myeloid markers actually, myeloid usually is NAC stain for monoblast actually, and also use the Sudan black B and also use myeloperoxidase stain for the myeloid cells. But for the lymphoblast, you need to keep in mind you usually use the PAS stain, and PAS stain shows block positivity because they have glycogen granules in the lymphoblast. And PAS stain can also be positive in M6 variant of acute myeloid leukemia and M7 also, particularly the erythroleukemia M6, which is also known as Digogliomos syndrome. So these stains things you need to know. Another thing they would be asking about the immunophenotype marker. Particularly they love to ask about TDT, terminal deoxynucleotide transferase, which is typically seen in lymphoblast, both B cell and T cell lymphoblast. CALLA, common ALL antigen CD10, could be also present in the B cell ALL particularly. And in the AML, the markers which would be there would be CD13, CD14, CD15, CD33, CD34 also, and CD117. So please keep these things in the mind. And they also love to ask about the 4 subtypes of the AML. Key subtypes in the WHO. One is AML associated with recurrent genetic abnormalities, AML associated with myelodysplasia, dysplasia-related changes, AML associated with therapy, particularly the alkylating agent and topoisomerase 2 inhibitors, and also the AML not otherwise specified. This is another key concept. And ALL particularly ALL is the most common cancer seen in the children, and ALL particularly need to concentrate about the B cell ALL versus T cell ALL. B cell ALL is the more common variant, 80 to 85%, 10 to 15% is seen in T cell origin ALL, and B cell ALL actually more common in the first decade of life, majority of them, and T cell ALL usually seen in adolescents because involvement of the thymus is seen, and that can present with a lymphoid mass. So these are the key concepts that you need to keep in mind of the acute leukemia. There are many things more, but in the short span of time, these are the things which are coming in my mind. Particular key is that you need to understand what is acute leukemia. Acute leukemia is characterized by more than or equal to involving, even it is 20%, still it is acute leukemia. More than or equal to 20% blast in the peripheral blood or bone marrow. And there was an older FAB classification system which was introduced in 1976, but currently we follow the WHO. And WHO FAB, the cutoff limit was 30%, but currently in the WHO cutoff limit is 20%. This is the need to understand. You need to know of the risk factors, particularly in the acute myeloid leukemia. Read out the acute promyelocytic leukemia, read out the translocations also, and the risk factors, and what are the favorable prognostic factors for ALL. So please go through this. So this is all coming in my mind right now. Continue with the discussion in the coming session. Thank you very much.